Today's case is that of a 70-year-old female. She presented with fatigue, weakness, black stools, and having a decreased level of functioning, and also suprapubic pain. It appeared that she had a stroke and became bedbound and aphasic a month ago prior to presentation. She also had a background of type 2 diabetes with no previous history of antimicrobial use. In terms of the physical examination findings that I obtained from the clinician, there was a temperature, she was pyrexial with temperature of 38.2, and she was normotensive. And in terms of cardiovascular examination, it appeared that she had normal heart sounds and no stigmata of infective endocarditis. Otherwise, her examination showed findings that she had a dense left hemiplegia, possibly as a result from the cerebrovascular accident. The clinician had placed a transurethral catheter and it drained 1.5 liters of urine. In terms of blood investigations, her urea and creatinine was markedly elevated. White cell count was elevated at 24, and the platelets was 277, and CRP was 107. And she tested HIV negative as well. And HbA1c at the time was 10.7. In terms of other investigations that were done, the ECG showed sinus rhythm at 98 beats per minute. The lung fields were clear. The abdominal ultrasound showed bilateral hydronephrosis. At the time, they did not do a gastroscopy due to a poor baseline, and she was appeared unstable. So the initial assessment was that she had delirium secondary to possibly a UTI, and acute renal impairment secondary to obstructive uropathy, and had upper GI bleeding as well. In terms of microbiology results, there was a blood culture done on the 12th. After 37 hours of incubation, there was growth detected, and the gram stain showed yeast cells. We had cultured Candida glabrata that was susceptible to amphotericin B, caspofungin, micafungin, and flucytosine. And the clinician had started on amphotericin B initially. And subsequent blood culture 3 days later also cultured Candida glabrata as well with similar susceptibilities. She also had a urine culture done, which showed, which cultured E. coli that was carbapenem-resistant Enterobacterialis. That was OXA48, and that was treated with fosfomycin. And subsequent blood cultures, 2 other blood cultures had that was repeated, showed no growth. She had echocardiography done, and a large vegetation was seen on the mitral valve. So for this case, Candida infective endocarditis was diagnosed. So I'm just going to speak a little bit about this particular condition. So in terms of Candida glabrata, there's been a revised name to a difficult name, Nicotiomyces glabrata. It is not really well accepted yet because its clinical utility is uncertain, and but also there must be a balance with phylogeny. So in the community, it's not a well accepted name yet. And in terms of fungal endocarditis, there was an Italian study done on endocarditis with 1,456 consecutive episodes of endocarditis from January 2004 to December 2011 in 25 institutions. And there were 20 episodes, which constituted 1% was due to fungal etiology. There were also retrospective case reviews of 270 cases over 30 years from 1965 to 1995 that were published, and fungi was noted to be responsible for only less than 10% of infective endocarditis cases. The fungi most commonly isolated were Candida albicans, which constitute 24%. Non-albicans species of Candida was 28%, which composed of various species, and Aspergillus species, Histoplasma species, and recently emerged fungi accounted for the others. There were limitations to this review as it failed to reflect a wider picture of fungal endocarditis because of the bias inherent in selecting cases for publication. But the rarity of fungal endocarditis may be a factor promoting the publication, and this review covers a large time frame. There's also been an increase in the incidence of all forms of candidiasis in recent decades. This review also reported on substantial changes in the percentage contribution of the most common risk factors for fungal endocarditis seen over the years. So on the left, we see that the incidence of vascular lines, surgery other than cardiac, immunocompromised patients, and IV drug abuse has shown an increase. In contrast to the right, there was decline in incidence of the percentage contribution from previous valve surgery, antibiotic use, rheumatic heart disease, and previous bacterial endocarditis and other valve diseases. Other clinical factors that have been reported in literature that's associated with Candida infective endocarditis are native or prosthetic valves, include cancer chemotherapy, implantation of prosthetic valves, post-cardiac surgery, as well as heroin addiction. There's also been a retrospective cohort analysis that was done at a tertiary hospital at St. Louis, Missouri in the USA from January 2002 to January 2015, where 1,873 patients with candidemia was looked at, and 47, which constitute of 2.5%, were identified to have Candida infective endocarditis. They had analyzed the data with a multi-variable logistic regression, and they found that those who had valvular heart disease had higher odds of having Candida infective endocarditis, whereas infection with Candida glabrata, having hematologic malignancy, and those who had received TPN had lower odds of having Candida infective endocarditis. So the ITSA 2016 guidelines on the management of candidiasis also suggest to suspect this condition when the blood cultures are persistently positive, when a patient with candidemia has persistent fever despite appropriate treatment, and when there's finding of a new heart murmur, heart failure, or embolic phenomena occurring in the setting of candidemia. So the valves most commonly involved are the aortic and mitral, and this picture shows vegetation involving Candida parapsilosis on the aortic valve. The pathogenesis is not quite fully understood. Patients who undergo cardiac surgery are at increased risk of candidemia. It might be they are being exposed to multiple antibiotic exposures, and they have prolonged intravenous catheters and fluid administration. And the damaged endocardium and the prosthetic material can act as a foci for localization of Candida as well. There's also been reports of contamination of suture material and homografts and heterografts before insertions as well, that they thought contributed to the pathogenesis. In terms of virulence factors, the switch of Candida albicans from yeast to hyphal phase has been reported as one of the virulence factors. But whereas in contrast to Candida glabrata, it's able to cause lethal infection with no hyphal transformation. The ability of Candida to form biofilms is also attributed as one of its important virulence factors. Hypha-associated genes such as HWP1 and genes with a agglutinin-like sequence gene family and other genes play a role as adhesins. And protease and phospholipases are involved in cause damage to tissue, as well as Candida lysin, which is a cytolytic peptide toxin secreted by Candida, can cause mucosal epithelial damage and impair host fungal recognition. This is just a schematic showing the 3 stages of biofilm formation by the various Candida species and showing their different capacities to produce extracellular matrix and the varying components and the ability to exhibit different cell morphologies. These differences have implications in the persistence of colonization and infection, but also antifungal resistance typically found in these biofilm cells that acts as a barrier to drug diffusion and overexpression of drug-resistant transporters. In terms of fluconazole resistance, the predominant mechanism of azole resistance described for Candida albicans is increased expression of efflux pumps and also point mutation of the ERG11 gene that causes an alteration in the gene, causes alteration encoding the azole target 14 alpha demethylase, which is involved in fungal ergosterobiosynthesis. In terms of Candida glabrata, it is intrinsically less susceptible to fluconazole than Candida albicans. It appears that ERG11 does not appear to play such a major role, but other induction of other efflux pumps appear to play more of a role. In terms of Candida glabrata antifungal resistance, in a global set of Candida glabrata isolates, approximately 11% of the strains were classified as fluconazole resistant. And in another study, 6.9% was classed as such. And the frequency of resistant isolates vary by region, and the resistance rates also vary with underlying comorbidities. There's also a strong correlation between fluconazole resistance and voriconazole and posaconazole resistance. And more recently, fluconazole-resistant Candida glabrata strains have also reported can also be echinocandin resistant as well. Prof. Govender had published an article where they had done a laboratory-based surveillance on candidemia that was undertaken from February 2009 to August 2010 in 11 public sector hospitals and more than 85 private sector hospitals across South Africa. And this survey showed a dominance of triazole resistance, non-Candida albicans species, particularly Candida parapsilosis. And this suggested that will limit the choice of appropriate antifungal agents that can be used. And just highlighted in the red are those distribution of those that are resistant. In terms of its clinical presentation, the findings are not significantly different to those of bacterial endocarditis, except there's occurrence of large emboli to the major vessels. In terms of clinical assessment and diagnosis, blood culture is often utilized, and the overall sensitivity for blood culture for diagnosing invasive candidiasis is roughly 50%. And the limit of detection of blood culture is about less than 1 colony forming unit per mole, which is at or below that of a PCR. And it should be positive in vast majority of patients who have active Candida bloodstream infections. However, blood culture can be negative in cases where the level of candidemia is very low, or if candidemia is intermittent, or there's deep-seated candidiasis that persists after the bloodstream has been sterilized, or the candidiasis has occurred after a direct inoculation. The drawbacks of blood culture is that it's limited by slow turnaround times and can become only positive relatively late in the disease course. Other tests that have been suggested as adjuncts include beta-D-glucan, and it's got a high negative predictive value, but it has issues with specificity and false positivity. And antibodies also have similar issues where its antigen detection is limited by rapid clearance from the bloodstream, so it's not very specific. But however, in cases of invasive candidiasis, it can become positive early on, even prior to a blood culture. And in terms of PCR, its role in early diagnosis and management remains unclear. The unresolved issues with PCR is that there's a lack of standardized methodologies, and it hasn't been validated in different centers on how the assay performs. We are currently at Grooteskuur, Nasli and Clinton, and they are validating a fungal PCR. So we'll hear more from them as well. And in terms of echo, there's been false negative results can occur, and especially in the case of mural endocarditis. Transesophageal echo have improved sensitivity if it involves the mitral valve. In terms of antifungal susceptibility testing, the CLSI and UCAS have breakpoints established for most and not all drugs. Clinical breakpoints have decreased from previously established, and with glabrata, there's no breakpoints established for fluconazole, itraconazole, posaconazole, or voriconazole. And where there's no breakpoint established, the ECOF cutoff value can be used to see the distribution of the MICs within a species. In terms of amphotericin B susceptibility testing, UCAS has published clinical susceptibility breakpoints for Candida albicans, Krusei, glabrata, parapsilosis tropicalis. However, CLSI have not published amphotericin B breakpoints. And UCAS have also revised the definition of the susceptibility category intermediate to susceptible increased exposure. And this implies that the drug concentration, if the drug concentration at the site is high, either because of dose escalation or other reasons, it can be used. So in terms of optimal therapy, in adults, it's a combination of valve replacement and a long course of antifungal therapy. And medical therapy alone has occasionally been curative in adults and children, but is generally not recommended. And the combination therapy is recommended for both native and prosthetic valves. And these are based on case reports, case series, studies and clinical experience. And in terms of antifungal therapy, the ISA guidelines recommend liposomal amphotericin B with or without flucytosine or a echinocandin for initial therapy at slightly higher doses than usual. And also then the step down is fluconazole 400 to 800 milligrams for the organisms that are susceptible and patients that are clinically stable and who have negative blood cultures subsequently. In terms of management, they strongly recommend valve replacement and after surgery, the antifungal to be given at least 6 to 10 weeks and monitoring a minimum of 2 years post-operatively, and suppressive therapy to be given lifelong if it's not feasible to remove the valve. In terms of a prognosis, there were 70 cases of Candida infective endocarditis from the ICE prospective cohort study, and that was collected between 2000 and 2010. And the all-cause mortality was 36% in hospital and 59% at 1 year, which is quite high. And that has been similar to what has been reported in the literature in the past. And there's also cases of relapse after surgery reported. In terms of the outcome of the case, due to a poor baseline, it was decided that the patient was not a candidate for surgical intervention. And it seemed like the team looking after the patient, they had decided with palliative care treatment. And in conclusion, so Candida infective endocarditis is uncommon but severe infection that can have frequent embolic complications and a high mortality rate. A high index of suspicion and knowledge of the groups at risk is required for the diagnosis. There are unresolved issues with diagnostic tests, particularly non-culture diagnostics, and therapeutic choices can be limited, and antifungal resistance aggravates the problem. And medical and surgical combined approach is the cornerstone of therapy. So that's it from me.
Thanks very much, Edward. A very nice presentation, very comprehensive look at this problem. While colleagues are deciding on their comments, perhaps I could ask whichever consultant was working with you on the case from microbiology to make some comments. I don't know if that was Elizabeth, Adrian, Chad, Nasli.
It wasn't me, Prof. I'm not too sure.
Okay, I'm not really interested in who it wasn't, Elizabeth. I'm interested in who it was. So, but I mean, please, by all means, let's have your thoughts on it.
Okay, I think it's an interesting case, and I just wonder if perhaps the source wasn't her GIT. They never established what was going on with her GIT, because Candida glabrata, although obviously all Candida species do colonize skin and GIT, Candida glabrata is known to be more a colonizer of the GIT than it is of the skin. So that could have been the source of her infection. Which yeah, so I think that's interesting. And also just in South Africa, we're quite lucky in that at the moment our glabratas still remain quite susceptible to the echinocandins, which in other countries, like Edward mentioned, they're not. There's often a bit of a cross-resistance. Well, not a cross-resistance, but a resistance issue in both groups.
Great, thanks very much. Adrian, what are your thoughts on the case and on this sort of Candida endocarditis. I'm sure you've seen a lot in your time.
Mark, no, I've got nothing to add. It's an uncommon bug, and unfortunately, there is some, well, not here yet, but in places where a lot of caspofungin is used, a slow accumulation of some of the FK resistance that develops. It's a kind of, to me personally, an enigmatic bug, per se.
What a nice thing to be. Okay, if there are no...
Can I ask a question? There's a question from Sipo. Can I ask a question?
Please, Sipo, yeah.
So just to the microbiologist, in terms of the non-albicans sort of Candida infections, I think so. The data would suggest that parasitolosis was more common than glabrata. Is that still the case, or is there a increasing? Are they flipping around? That's just a question in terms of what the microbiologists are seeing in the lab from hospital specimens.
Thanks for the question, Sipo. So I looked at 5 years at Hooterskier, and so our highest number is for Candida albicans, that was 1,407. And in second place is Candida glabrata, only 431 samples positive. I haven't broken it down into a year-on-year comparison to see if that's increasing or any of that, but I hope to do so with the new antifungal work we're doing. And then third is crypto, which is not surprising, neoformans. Parapsilosis is actually, let's see, 1, 2, 3, 4, 5, 6 on the list. 105 over 5 years. That's really low. And I must say at Barra, for example, I mean, you could get that in a month maybe. They have a completely different profile. So different areas in the country, yeah, certainly parapsilosis would be the highest, and I think in private as well, if not surpassed by the Auris yet. Yeah, thank you.